There's been tremendous excitement in the oncology and patient community over the past few years about increasing introduction of therapies that are targeting activating the patient's own immune system against a cancer, or immunotherapies. Could you tell us a little bit more about immunotherapy for the kinds of cancers that you treat?
Absolutely. Immunotherapy is, mind-boggling in my opinion. I never thought, like in my lifetime, we would see such unbelievable advances in what we perceive to be a completely new field. This was a field that didn't even exist years ago. And there have been such exceptional advances in use of immunotherapy for the treatment of many adult solid tumors. And so naturally, as you see responses in some diseases, the next best goal is to apply immunotherapy to the next disease and see if you can stimulate a response there as well. So there is already adult data in conventional hepatocellular carcinoma in particular, suggesting that use of immune therapy is promising. I think the challenge with fibrolamellar, as we've already mentioned, is that the disease is rare. We don't know whether it's been adequately or molecularly characterized in the past, although we think now that the vast majority of institutes are capable of looking for the genetic aberration and adequately identifying these cases. But we have a lot to learn as it pertains to the immune environment of these tumors. I keep going back to the patient heterogeneity because I do think every patient's tumor is a bit different. But certainly from what we've seen on a preliminary basis is that these tumors do harbor an immune infiltrate. And by that, I mean there are human immune cells from the patient embedded within the tumors. And that's important because immunotherapy capitalizes specifically on that topic. The fact that there are immune cells embedded within the tumor that you can potentially take advantage of and or reactivate. And so the whole premise of immune therapy is to capitalize on immune cells embedded within a tumor and hopefully reactivate them in a meaningful way such that those immune cells, which previously didn't recognize the tumor, can recognize the tumor and fight it. I think for fibrolamellar carcinoma, we have a lot to learn, but there's enough promise to suggest that immune cells are present and that they might be an excellent tool to direct our efforts on subsequently as a mode of therapy.
You've talked about the importance of getting objective data about how cancers respond to particular treatments. What are you doing to get that kind of data with immune therapy in fibrolamellar carcinoma and other liver cancers?
Thank you for asking. I have a vested interest in this. And so recently, myself and others at my institute have embarked upon a prospective clinical trial studying the use of a particular immunotherapy, checkpoint inhibition, which I can go into in more detail, for patients, pediatric patients in particular, with hepatocellular carcinoma. This clinical trial, as I mentioned, is prospective, studying the use of this drug in patients with both conventional HCC and fibrolamellar carcinoma. And a lot of this trial arose from data we had at our own institution. We had treated a handful of patients, pediatric patients with HCC, with checkpoint inhibition, and found remarkable variation in response. For some patients, we achieved stable disease for an extended period of time, which was in and of itself a win. For some patients, unfortunately, their disease didn't respond and continued to grow. But for one patient in particular, we achieved a complete remission. That patient was a fibrolamellar patient. So that got us thinking, on the basis of that preliminary data, this is something we should be rigorously studying prospectively to obtain enough evidence to determine whether we should continue to study immunotherapy in this patient population. As I mentioned, pediatrics is rare, and so our goal was to design the clinical trial and open it at a handful of institutions, such that we could more rapidly accrue patients and better understand the utility of this drug in this patient population. The trial is funded by the Cancer Research Institute, which has been extraordinary. I think having the opportunity to obtain support for a pediatric-focused endeavor is remarkable. The trial is currently open and enrolling at Dana-Farber Cancer Institute, i.e. the lead institution, Cincinnati Children's Hospital, the University of California at San Francisco, and will open at Texas Children's. And again, these are all pediatric institutes united to better study the role of this agent in particular in pediatric hepatocellular carcinoma.
So it's really encouraging to hear that there is at least one example of a pediatric fibrolamellar cancer patient showing a very strong response to the drug that you described. Maybe you'd like to tell us a little bit more about what a checkpoint inhibitor is and that approach to immune therapy.
Happy to. So checkpoint inhibitor therapy is an attempt to, as I mentioned, reactivate immune cells to recognize tumors. We know that the key immune cell that we are looking to reactivate, or the key immune cell that has been shown to best fight cancer, is the T cell. It's a type of white cell within the body that helps to fight infection, but also can help fight cancer. The problem in many patients with cancer is that these T cells tend to express on their cell surface a particular protein. That protein is called PD-1. Similarly, tumor cells express a protein called PD-L1. PD-L1 likes to bind to PD-1, and when the two bind together, the T cell gets inactivated. It's like a break. The T cell all of a sudden doesn't know how to function. It thinks the tumor's a friend, and it isn't activated to fight the tumor. The beauty of drugs like checkpoint inhibitors is that they break open that alliance. They interrupt that binding. So, for instance, the drug we're studying, pembrolizumab, binds PD-1. So it binds to the protein on the T cell surface. It keeps it from binding to the tumor surface. And in doing so, it eliminates that break with the goal of reactivating the T cell. Now, the trouble with this particular drug is that it doesn't specifically or purposefully reactivate the T cell. It doesn't tell the T cell, okay, now get the tumor. It just reactivates the T cell in general. But what we've seen from adult data and preliminary data in adult HCC patients is that these T cells, when activated, do meaningfully contribute to fighting tumor cells. They may inflame other parts of the body as a collateral, but the reality is what we've seen in pediatrics in much larger studies is that these agents are unbelievably well tolerated in our pediatric population. So our trial hopes to again validate the safety of these agents, but likewise the efficacy in this particular patient population that, if you haven't gathered already, I'm very, very inspired to learn more about and to really help improve outcomes for.
I can hear the passion you have about immune therapy for liver cancer in children, particularly fibrolamellar. If a patient or family is interested in getting more information about the clinical trial you've described, what would they need to do to get that information, and how would they go about enrolling in the trial?
Of course. So please reach out to me, Dana Farber. But no, I mean, the clinical trial is available to obtain more information about on clinicaltrials.gov. Again, searching under fibrolamellar carcinoma. You will likewise find my name associated with the trial on clinicaltrials.gov. I'm always willing to speak with patients, families, and providers. I think that is one of the greatest joys of my job, is reaching out to an extended network of people, particularly patients and families. And so even if the trial doesn't wind up being the right option for the particular patient of interest, it still allows us a meaningful opportunity to connect about what other options might be available or make the most sense. I think the other thing about the trial that I'm very passionate about is it will allow us the opportunity to better understand the immune infiltrates of these tumors, to better understand whether we take this even further. We think about even more complex immune therapies guiding the treatment of these patients. And I think we're only as good as our data. We as a community are only as good as the information that we learn rigorously and scientifically. And so my hope is, in better understanding the tumors of patients enrolled on this trial, I can better inform not only my own next initiatives, but those of my colleagues at other institutions, those in the Fibrolamellar Cancer Foundation, those equally as passionate about creating a better space, home, and care angle for these patients.